Hi, my name is Michael Muhonen. I am a neurosurgeon at Children's Hospital of Orange County, and I have been at Children's Hospital of Orange County for about 30 years.
Can you please explain more about what you do in your day-to-day job and what other careers you may have had?
So I am a pediatric neurosurgeon. I have been doing this since 1993 when I finished my training. I pretty much since high school always wanted to be a neurosurgeon. One of my younger brothers was hit by a car when he was 4 and I was in high school, and a neurosurgeon took care of him. And basically I said to myself, wow, I could take better care of this child than this doctor, because he never comes and sees us till 10 o'clock at night. Then he only spends 30 seconds with us. So it somewhat motivated me. Obviously the interest of the brain and the science interested me, but I was struck by the fact that he was so busy and so overwhelmed that he couldn't see you till late at night. And then you only got a short window of time with him anyway. When I was in medical school, I was still almost certain that I was going to be a neurosurgeon. When I was in college, prior to that, I was fairly certain I was going to be a neurosurgeon. So I stuck with it since high school. And you have a lot of opportunities to change your career. When you're in college, you can change your major. When you go to medical school, you can go through the early years and then decide what specialty you want to go into. So I had always had it in the back of my mind. I wanted to do something with the brain and probably neurosurgery. If you don't like to do surgical aspects of the brain, you can be a neurologist, where you treat things like epileptic seizures and sleep disorders and headaches and multiple sclerosis and things like this, but you don't do surgery on these patients. So that would have been my alternative, but I was more hands-on and really liked making things better. And I always kind of had this approach, and it's kind of a Boy Scout mantra: leave every place you go better than how you found it. And the same is true with the neurosurgeon. Leave every patient better than they were presented to you. And that's what stuck with me, is leave everything in a better state than when it presented to you. And it applies from everything to a head trauma that comes to the emergency room, to a brain tumor. You have a brain that's ugly with a tumor in it, you take it out and make it look better. And it's been a career that I really never had any desire to change careers from, and stuck with my plan that I would pursue this and probably not change. There are neurosurgeons that change their careers after they've done all the training, but it's very rare. Once you put in that much training, most neurosurgeons stick with it and pursue it.
So we read your bio and we noticed that you work on specific parts of the brain. What specific parts do you work on?
My main interest is in a condition called hydrocephalus, hydro meaning water, cephalus meaning brain, and that's in the deep parts of the brain. So we make about 2 cups of brain water every day called cerebral spinal fluid. That water is primarily in the middle of the brain, but it also coats the surfaces of the brain. So my area is in devices to drain excessive water buildup in the depths of the brain. And when you get this excessive water in the brain, you develop this condition, hydrocephalus, and it makes the head grow. If your skull's already closed and grown, it'll give you headaches, and it can affect the brain deleteriously. So my interest has been primarily in treating any condition where there is excessive water buildup in the brain and getting rid of that water. And along those lines, we've here at Children's Hospital of Orange County helped develop new devices that drain that water out, and they're called shunts. And these shunts drain the water from the head. Basically, it's a tube that comes here under the skin over the collarbone and drains it into the belly cavity. And we've helped develop some valves that regulate the flow, that let it out more uniformly so you don't drain too much or too little. And since I've started, my primary interest has been anything that deals with spinal fluid. How do we get access into the cerebral spinal fluid? How we can control excessive spinal fluid. The latter part of my career has been focusing on how do I get drugs into the central nervous system? How can I get them into these ventricles of the brain and the fluid around the brain? So for example, there's many medications and gene therapies we can put in the cerebral spinal fluid and reverse the effects of a very bad disease. There's some diseases, spinal muscular atrophy is the name of one of those. These are children that would typically die before the age of 3 or 4. We can now put a catheter in the back, guide it all the way up here, and inject a medication in there, and sometimes effectively cure these patients. But if they're older, we can stave off their symptoms and allow them to live a very good life.
How long was your education to become so specialized? How long did it take?
I don't want to discourage anybody, but it takes a long time. So you complete high school, you're 12 years of high school, 12 years of school, including high school. Then after that, you need to go to the university or college for about 4 years. And then you go to medical school for 4 years. So there's 8. And then you do an internship where you learn the doings of a hospital for a year. And then you do a residency for about 7 years. So it's 4 + 4 + 1 + 7. So that's 16 years right there. And then you typically, if you want to do children, add on another year or 2. So there's 17 years after high school of training that's required to become a pediatric neurosurgeon. And, you know, you're overwhelmed if you stood back as a high school student and said, wow, that's going to be 21 years from now. But when you're in the middle of it, it's, you know, college goes kind of slow and medical school goes fast and residency goes very fast. And before you know it, you're there. The drawback is you're not really getting paid during those 17 years. So you kind of get your first job when you're like 34 years old rather than when you're 19 years old. And I think like anything else in life, the more education you get, the longer you postpone your first paycheck with more degrees, the more monetarily rewarding it is and gratifying from the perspective you put in all this work. And now you're put in a position of trust because you've put in these 34 years of work, that somebody would trust their child for you to open up their head.
You mentioned brain tumors earlier. What are some things that neurosurgeons typically have to deal with?
Brain tumor is commonly things that we take out of, especially in children. The most common pathology that we deal with, depending on the center that we see in the emergency room, would be a head trauma. So children that walking across the street get hit by a car, or in my case, we live near Disneyland. We have kids that the father's holding up on their back and they fall off their shoulders when they get excited and land on the pavement. So head trauma and spinal cord injury is very common. My subspecialty being water on the brain, I deal with children that have these tubes, the shunts that drain the water. And about 60% of my practice is dealing with excessive water buildup on the brain and dealing with the tubes that plug up. Other people in my group, there's 5 of us in the group, one of them deals primarily with spine and spinal cord insults like spina bifida, herniated discs, spines that are turned with scoliosis. Another one in my group got a PhD in brain tumor research, and he likes to take out brain tumors. So those procedures typically in children are in the back of the head, where most brain tumors occur in children, where you open up the skin, take a piece of the skull out, open up the sac around the brain, and then using a high-power microscope, go in and take out the brain tumor away from the normal tissue while doing your best to preserve normal tissue. And then another one of my partners specializes in functional neurosurgery. So kids that come in that are real rigid and stiff like this, he puts stimulators deep in the brain with a generator, and it can shock the brain to make these kids have fluid movements of their hands and legs, treating conditions like cerebral palsy and dystonia. So there's a vast gamut of what we call subspecialization. So yes, we are pediatric neurosurgeons, but we have our own little specialties.
Do you ever feel sad, like with these cases of children who have these, horrible diseases?
It's a good question, because sadness is a very appropriate word. If you didn't have sadness for this job, it would say you don't care. But the reality of the situation is you have to deal with death. If kids have brain tumors, some of them are going to die. If kids get hit by a truck, some of them are going to die. If kids fall off the top of a roof, some of them are going to die. So that's the reality of it, is that it is a field that has sadness. And it's something that you try to dissociate the sadness away from your family. And it does make you, almost every day of my life, come home and hug your children, because you know that they could have been that child that you encountered today that had this unfortunate pathological state. So sadness is a daily thing that we encounter. Overcoming that sadness by doing your best to treat that patient is the joy we get to counteract that sadness. I have spoken at probably more funerals than far most people have. In fact, if I look in my file here, I have a file called Funerals, and it's about this thick of all the funeral talks that I've given at patients and families that I've become a big part of their family by operating on the child multiple times. But eventually the disease or pathology progresses and they pass away. So I don't enjoy speaking at funerals, but it's part and parcel, I think, of the healing process of helping the family and the friends get through the illness, explaining to them how the child died and why the child died before the parents died.
The impact you have on people and your job, like how heavy does your impact have on these people?
Well, I know the impact is big, and you see this on a daily basis when it's a mother that Monday morning at 7:30 hands you her baby and trusts you with that baby's life, that you're going to take the tumor out or treat the condition. And universally, they hand you the baby and they cry, but they cry with an assured trust that, you know, they respect you and trust you and know that you're going to take good care of their child. And the families, when you deal with pediatric neurosurgery, you're really trying to get the family through the illness. If you operate on a baby, the baby doesn't care. The baby is put to sleep and you do your thing and the baby wakes up and has their mother. But getting the family through the illness and them trusting you, I think is a huge part of the job. And that's part of being a good physician, is creating a bond of trust between the patient and between the patient's family. When you turn 18, it's not an issue where it's the family anymore. The patient doesn't have to have their family involved, and they give their own consent. So it really is a specialty where you have to have a relationship with the patient and the family and foster that relationship by showing that you care.
How do you keep yourself motivated to keep going after these hard cases and sometimes even deaths?
One thing I will say is that every single day that I have woken after the last 30 years, I look forward to going in and doing the procedure. I almost can't wait to wake up. It's that exciting. So I think the motivation is that you're doing something that is dangerous. You're doing something that is life-threatening. You're doing something that the patient could die from. And so it's not so much that you need motivation. There's a little bit of a fear factor. There's an anxiety factor. I think the sleep is poor every night. You have a big case the next day because you know what can go wrong. And so motivation is not needed. There really is no motivation needed. There is more of a physician burnout that I have seen, especially since COVID, where physicians feel like they've just gotten bombarded with pathology and bombarded with patient calls. And I have seen quite a bit more physician burnout, where they're just like, I can't do this anymore. The burden is too harsh. So you have to balance your life, and you have to avoid burnout to stay motivated. And every spare minute that I have, I must say I am doing something. I really feel like I've done something with my kids whenever I can. I go golfing when I can. I go fly fishing when I can. And that you need a balance to stay motivated. If you do nothing but work, if you work 18 hours a day, you will lose that motivation.
How long do those surgeries take, and how do you maintain like a work-life balance on your long days?
So the longest surgery I ever did took 23 hours, and that type of a procedure is rare, but it does happen, where you have a tumor that's deep in an important part of the brain, and it just takes an inordinate amount of time and patience to get it out without hurting the normal brain tissue. The average surgery takes a couple of hours, and those are fine. It's easy to keep your focus for a few hours. It's even surprisingly easy to keep your focus for 8 hours when you're under a microscope. What's unusual about it, when you've operated on something for, say, an 8-hour procedure, and you're under a microscope when you're taking this out, and you haven't eaten, and typically you don't have anything to drink, but when you're done with it, when you take it out and you're ready to close everything up, which is much less stressful, I always get this nauseous, hungry feeling, like, wow. But during the stress part of it, your body's secreting enough endorphins and stress hormones that you don't feel the hunger, you don't feel the thirst, you don't feel the need to relax. But it's the minute you're finished and the anxiety and the stress are gone, it all hits you. Your body's like, help me. You need to drink, you need to eat, you need to take care of yourself.
I had one question. Was it just your experience with your brother that drew you towards the pediatric field, or were there other factors that made you want to work with kids?
I think one of the biggest factors was my brother, but I grew up in a family with 10 children. And I think the pediatric aspect of it was that I was always around children and was not around adults, I think. And I've always liked the child mind, I think, and was fascinated by the development of the brain. And as I got into it, I never regretted that decision, because it was always one where maybe it's my childlike mind. I could relate to children very well, got along with children very well, and babies to teenagers, I never had a problem relating to them and getting down on their level, whether it was with magic tricks and jokes. And I've had a lot of patients say, well, you don't have a serious bone in your body. Yet I had other patients say, well, you don't smile very much, you're so serious. Well, you do what's appropriate for the situation. You don't necessarily pull jokes on a 10-year-old that has a brain tumor. You got to get it appropriately for the situation.
Back to what you said earlier. So would you say that if you became a neurosurgeon for the money and not because like you had your heart in it, would you say that it'd be very hard to like stay motivated and stay in the job?
You would have to really love money to stay in the field only for the money. But that being said, I know some people that have had that attitude and done it, and those same people have always left the field early. They tried to make their money fast and then leave the field rapidly, because you don't have a motivating force to drive you to do neurosurgery once you've achieved the monetary reward.
We know that doctors and any like people in the medical field have a lot of student loans and student debt, and you also start working a lot later than a normal professional, how do you overcome this, the student loans?
So the debt load of a typical neurosurgeon right now is going to be about $300,000 to $500,000 when you're done with all of your training. And you have to look at from a financial perspective. Well, I'm going to make $500,000 every year for the next number of years that I work. So it's overwhelming if you stand back in the middle of it and say, I'm a $250,000 or $500,000 in debt. But you can't do that. That's way too overwhelming. But that should motivate you to finish, knowing that you've created such a tremendous amount of debt also. But in the big picture, you're going to recover it. It's kind of like, planting the seeds for the harvest in the fall. That's all you're doing, is planting all your seeds and planting them, and that student debt is seed money. That's how I looked at it. And I got them paid off within a few years. It wasn't overbearing. I always hated to have debt, so my goal was to pay that off rapidly.
What are some of the biggest struggles you've had in your career?
It's usually dealing with a patient death. Yeah, I have done, the number was like 10,800 procedures, and I cannot recall the majority of those, but I can certainly recall the ones where patients died. And I can recall the entirety of the procedure where a patient died. Yeah. The struggle is, how do you get back up on the saddle and do a procedure after you've had an outcome that's not desirable? And that's the hardest struggle, I think. So you have to have a strong ego, and you have to have trust in yourself.
What does your day-to-day life look like?
Repeat that.
What does your day-to-day life look like?
So typically the day would start at 6, and you would you go in the hospital, you want to be there by 6:30 to see the patients from the day before, patients that are traumas in the ICU. And you'll typically meet your physician assistant or the students and the residents. You'll see the patients in the hospital that need to be seen on a daily basis. Surgery then typically starts at 7:30. Do surgery till maybe the afternoon. In between surgeries, you'll typically see a patient that's been put on the schedule to be seen urgently. And then after your surgeries are done, I would have, if my surgery finished at 2, then I would have maybe 10 patients scheduled from 2 o'clock until 5 o'clock. And then once the office is closed, you go see the patients that you've operated on that day again, check on them and make sure that they're not having any problems, and check their blood work. And some of them have had CAT scans and MRIs, and you want to check those. And then there's always some paperwork that's left over from the office, and that's probably the biggest nuisance that physicians face today, is that everything is electronic. So you have to do all the computer work, and the billing charges and the notes in the computer. It used to be, when I started, you just wrote it by hand, and it was fast and quick and easy. But now you have to enter the computer data, and that's been difficult from a time perspective. And then by that time, it gets to be 7, 8 o'clock at night, and you wind your day up. Depending on how many are in your group, you're going to be on call, so you have to man the emergency room. And one out of 3 to 5 days when you're in the emergency room, they'll call you. The trauma typically comes in before midnight because kids aren't awake after midnight. The brain tumors can show up whenever. So when you're not on call, you can go home, and then one of the partners mans the emergency room after that.
Do you teach any interns or residents? And if so, how is your experience with teaching?
Yes, we virtually 100% of the time we have a student or a college student or a medical student on the service. We also have doctors in training called the residents. So they come from University of California Irvine, and they have to do 1 year of pediatric neurosurgery. So you have a doctor that's already a doctor, but they haven't finished the neurosurgery. Typically, they're in the middle of the residency, like maybe their 4th year. So you have them on the service. You'll have a student on the service. This summer, I had 3 students on the service from various universities. The hospital doesn't allow high school students in there, but they allow college students and medical students. And that's part of the teaching process. The physicians owe it to the community to give back a portion of our knowledge. So it's very common that we do have students. There's also a lot of physician assistant and nurse practitioner students that want to rotate through neurosurgery. And it's just part of the job is that you're going to teach. I give lectures to the residents in general pediatrics commonly, probably monthly. I give a lecture. Since I started to slow down in general neurosurgery, I run a laboratory. And my laboratory has 7 employees, and these are PhD doctors and biomedical engineers as we try to make different devices for neurosurgery and devices that help treat the water buildup on the brain.
Do you do surgery every day, or is it different like for each day?
It's different each day. There are typical days in the week where you only see patients in your office, and these would be babies that follow up from surgery. A baby might come in with a bump on his head, and they want you to see that. You'll see somebody that had an MRI the day before, and they found a brain tumor. So you have an office where you see patients in what we call the clinic. And then a half a day a week, I go to a subspecialty clinic. So only seeing patients that have a particular problem. For example, patients with cerebral palsy, you see them to manage their rigidity and spasticity. 2 times a month, we go to a spina bifida clinic. These are children that are born with an open spine, hence the name spina bifida, and you manage all those patients in this clinic. So the operations are about 3 days a week. Clinical patients are about 2 days a week. And I try to go a half day where I just catch up on paperwork and write letters of recommendation and answer letters to patients and write prescriptions for wheelchairs and physical therapy and things like that.
Okay, kind of going on a different track here. How do you think neurosurgery will evolve within the next 10 years?
So everything's getting smaller and more precise. It used to be if I wanted to take out a brain tumor that was, say, right here near the speech area, I would open up the head, yay, and a big question mark. Well, now the computer, it's called stereotactic computer, can tell me, well, the lesion is right here instead of right there. So now I only have to open the head like this because I can precisely know where this is based upon the computer guidance. Before it was an estimation. So incisions have gotten smaller. The other treatment is gene therapy and putting viruses in the brain that carry a new genetic content that it can pass off into the brain to reverse pathological states. So the best summary is that things are getting smaller, things are getting more precise. Neurosurgery was a very macro field when I started 30 years ago. Now it's a very micro field with smaller incisions and a more precise attack of the pathology. Neurosurgery still cannot be done by a robot. It's not something that it's too fine and precise, I think, to trust a robot, but it wouldn't surprise me if it evolves into that eventually. The problem you have is you say, okay, well, a robot to do the procedure, it can't stop a bleeding artery, for example, like we can. We have a little cautery device, and if it bleeds, we just buzz it and stop the bleeding. And we just don't have the precision with any robotic surgery yet. You can take out like a gallbladder with robots and the surgeon's running it with robotic arms, but we don't have that expertise yet for neurosurgery.
What has been your proudest moment in your career so far?
I have a couple of them, not just one proudest moment, but one is I got to walk one of my patients down the aisle when she got married. She didn't have a father in her life, and that was a very proud moment. other proud moments are when students that have followed me and were thinking about going into neurosurgery have graduated and become neurosurgeons. And that's now happened 3 times in my life. So proud because I knew that I made an influence in their life in a positive way, that they were going to pursue this career and just, try to be like Mike. And those were proud moments.
So going back to talking about neurosurgery evolving and your work in your laboratory, I noticed in your bio you talked about doing clinical trials and research. Can you share a little bit about that?
So we are at a children's hospital that promotes research, and we really love to do clinical trials because that's how you discover what's best for the patient. So a clinical trial is when a patient lets you implant a device or give them a medication or do a study on them on something that's not yet approved by the Food and Drug Administration. So the clinical trials allow us to test this device, and the patients receive a little bit of compensation, but we receive a huge amount of information from these clinical trials. So I've been involved in multiple clinical trials where we would implant a new device in the brain that drains water, for example, and we would try to see if this worked better than the existing ones. And I've been in clinical trials where we've injected various things into the brain to see if it works. And the clinical trials are what make us evolve. Medicine would not improve and our care would not improve without clinical trials. We wouldn't have a vaccine, for example, without clinical trials. It has to be done to prove efficacy. So you think, well, why don't we just do clinical trials on animals? It doesn't work that well generally because they don't have the same disease pathology state. So clinical trials are a big part of the clinical practice, especially at university hospitals. If you go to a small general hospital in the community, you're probably not going to get into clinical trial, but any pathology at a big university hospital, there's going to be a trial. Some of them might be as small as we just want to check blood pressure changes after your surgery, to something as, hey, we want to try a new implant in your brain to see if it will melt the tumor away. So I'm a huge fan and advocate of clinical trials and research on patients. Along those lines, you have to have an informed consent where you tell the patient and their family what they're getting into and all the potential risks. And I'm a part of a committee called an institutional review board where we look at these, and it's our responsibility to protect the patient. And we're very serious about protecting the patient on these trials. And if the risk is deemed too high, we won't approve it.
Have you been a part of a successful clinical trial?
Yes, there's a couple in particular. One was for a device called the Strata valve. And the Strata valve was a shunt tube, a regulator that we could put a magnet on the patient's head and dial the pressure up or down. And we were able to successfully get this to market and change the pressure in the patient's head merely by putting a magnet on their head and dialing it up or dialing it down. And then another one that's been very successful is putting some medical treatments directly into the brain tissue and reversing the patient's brain disorder.
What advice would you give to people our age or older who are kind of interested in neurosurgery?
I have absolutely loved my career and I have no regrets. I'm kind of sad about the amount of time that I was not able to give my children as they grew up. But my advice is, if you have an interest in a particular part of the body and you have a scientific interest, I would urge you to pursue it. You'll read things in the papers and online about, well, medicine is changing and doctors are burned out and don't like it as much as they used to. I just have not experienced that. If you're doing it for the right reason, to improve science, to find a cure, to help the patients, it'll be the most fulfilling career one could possibly have. And there's just no greater trust that you could have than to hand your child off to a physician and say, operate on my baby. And I think it puts you in a field where it's life and death is trusted in your hands. And in that regard, I think it's probably the most rewarding field you could possibly enter from a self-gratification perspective.
You obviously have a very busy schedule. How much time do you typically spend away from home?
I have prioritized weekends with the family. I prioritized evenings with the family. And I looked at my schedule this year, and I only had, up until the end of September, I only had 4 weekends at home. So we really do prioritize doing things and getting out and then exploring the world and living life. And my children have learned that. They have all been to at least, I would say, 15 to 20 different countries. They've been, one of my daughters lived in Brazil. Another one of my daughters lived in Spain. They've really learned that the world is not just this small city in California. And they've learned to understand other cultures and enjoy life while you can. And that's one thing neurosurgery teaches you, is that life can be short and life is fragile. And every moment of your time, you have to live like you're not going to be here tomorrow. And that's what I've always tried to stress to my children. We're going to take what time I can give you, and we're going to enjoy this life and get to know the whole world. And the things that we like, we're going to do them again. The things we don't like, we're not going to do them again.
Do you have any hobbies for yourself that you like to do in your free time?
I do. I very much enjoy fly fishing. Let me show you. I'll see, I don't know if this picture will come through, but this is, and you might appreciate the solitude of why I might like it. But let me see if this shows up. Doesn't.
It does.
It kind of.
Yeah. Well, so anyway, that's me fly fishing in the middle of a river, and there's no one around me. So that's you. I have a moment where nobody can call me, no one can text me, no one can page me. It's quite funny. After this last trip, I came out of the wilderness, and I was there for, maybe it was probably 28 hours, and I came out and I had 80 some texts and 300 emails that had hit me in a 24-hour period there. And I was laughing that I guess I'm still loved or wanted. I'm not sure which, but and that raises another point, is that my phone has been given out to so many patients and families because we've tried to make it a point that if you need to get hold of me, just text me directly. I don't want you to go through an office and an exchange, then an operator, then a secretary, and then the student, and then the resident. If you really need to get hold of me, just text me or call me. And I will say, over the 30 years I've been doing this, it has not been abused. The families respect that. They call me when they need me. They text me when they need me. And it's not a system that's been abused. But my phone number is all over the world now because of that.
Okay, I think you've answered all of our big questions, and we learned a lot about your career.
Yeah. So
Thank you so
you so
much.
much.
Thank you so much.
No, you're sure welcome. It was a pleasure, and it would, be a great thing in my life to see one of you a neurosurgeon someday, if not all of you.
maybe we will. Maybe.
Hey guys, hope you learned something new from this video.
Please make sure to
Like, subscribe, and share with all your friends.
Bye!